Welcome to the COE Fidelity Guidelines tutorial on care management. In this tutorial, we will be reviewing the fifth section of the COE Fidelity Guidelines, care management. We do want you to be aware that the slides we're using for this tutorial present the Fidelity Guidelines along with additional resources to support guideline implementation. The written items on the slides themselves may be an overview of a guideline in some instances, so you should refer to the full Fidelity Guidelines document as opposed to the slides used in this tutorial if you need a reference of the written guidelines in their entirety. COE care management services may include activities such as supporting clients with reducing substance use, assisting clients in accessing or re-engaging with services, enhancing recovery capital, for example, social support, removing deficits in HRSN or SDOH, working with family members to support the client, enrollment and recertification of Medicaid, or assessing clients' needs for the previously mentioned services in other tutorials, such as the ASAM LOCA, locator form, or risk of disengagement. One of the items mentioned in the section about care management activities is the client locator form. This is a form that COEs can use to collect information from clients to reach out for general appointment reminders, connections to internal and external services, and/or to assist in re-engagement of care. You can find a copy of this form in Appendix 17. COEs are encouraged to offer a variety of visit frequencies and venues based on clients' needs, goals, and preferences. An individualized approach should be reflected in care management notes and data. At least one COE care management visit each month should be 15 minutes or longer. To carry out the guiding principles of the COE, mobile engagement is encouraged based on client need and preference. It is recommended to follow your COE's organizational policies, but consider incorporating strategies to engage with clients in the community, which could help prevent client disengagement. Clients who prefer office-based care management visits are not required to complete them in the community. However, mobile engagement is an important component of the COE program, as the intention of COE is to engage individuals who do not respond to the traditional SUD system and therefore may require more proactive engagement to remain engaged in services. COEs should have a documented mobile engagement policy that indicates how they will provide this service based on need and preference of the client. In addition, telehealth should follow organizational and Pennsylvania Office of Medicaid Programs and Office of Mental Health and Substance Abuse Services policies. In Tomorrow's Healthcare, you can find recorded trainings that may be useful for implementing mobile engagement. The sessions Utilizing Mobile Engagement Teams and Proactive Outreach highlighted the processes that current COEs use to engage clients outside of the traditional office setting. The care management section also expands on the extended care management plan, which should be initially developed by the end of month 2 and updated every 6 months or sooner if there is a new need identified. Care plans should contain the client's phase of recovery, which will be outlined later in this tutorial. The phase can be designated by the COE based on assessment and clinical expertise. When a new need is identified, the care plan should be updated to reflect that need if it is something the client will be working on in the long term. Care management support for short-term needs can be reflected in the EHR note, but may not require a care plan update if the need is addressed in one care management visit. Extended care management plans should include the client's treatment and non-treatment needs as identified on the full HRSN SDOH screening and goals, objectives, and/or action items to address those needs. Extended care management plans can also include client strengths and recovery-specific needs and goals. Extended care management plans should contain documentation, such as a signature, that the client agrees with the goals and participated in the development of the plan. The client, the care manager, and other individuals on the CBCM team, or as specified by the COE organization, should sign the initial and all subsequent care plans. Appendix 19 of the Fidelity Guidelines contains some best practices for care planning that may be helpful to review related to this section of care management. The care management section of the guidelines also stresses the importance of continuous assessment based on the client's stage of readiness and time frame in the COE. Consider 3 phases for the COE in terms of screening, with the first phase focusing on the first month, the second phase focusing on the next 3 months, and the third phase occurring in the 5th month approximately. Care management services can be provided through a stepped care approach based on the client's stability, for example, clinical status, and their needs. Care management services can be grouped into 3 phases over a period of 12 months based on clinical status. Please note that more time can be added beyond 12 months. All phases are considered guides, not mandatory timeframes. The phases include engagement and stabilization of substance-using behaviors, approximately the first 30 days in the first phase, integration of global health care issues and skills training to manage urges in months 2 to 4, and expansion of recovery capital and transition to self-management of OUD and SUD behaviors in months 5 to 12 or beyond. It is important to note that these timeframes are flexible based on individuals' recovery needs and are not requirements for COEs to follow for each client, but are a way that COEs can consider progression through COE services. One of the guiding principles of the COEs reviewed in the first video of this series was that the COE will function as a hub and spoke program for diverse community resources and treatment options. This concept aligns with the stepped approach outlined in this care management section of the Fidelity Guidelines, where clients are connected to services based on need throughout the 3 phases. This concept was emphasized in the MA Bulletin when it outlined that COEs should provide services such as primary care, including treatment for HIV, hepatitis and tuberculosis, perinatal care, mental health, drug and alcohol, and pain management. The MA Bulletin emphasized that these services could be provided directly or by referral, which emphasizes the hub and spoke model that is apparent throughout the care management section. In addition, the MA Bulletin stated that the COE should be able to provide access to forms of medication that are approved for use in medication-assisted treatment that are not provided at the COE provider's enrolled service location. This is where the use of both the hub and spoke model and the MOUD guide referenced in the initial assessment section could be advantageous to the COE. The hub and spoke model is designed with the COE at the middle of the hub and a team with carefully tailored care management resources to meet the individual's needs is built around the client through the spokes. The COEs are responsible for addressing their clients' full array of clinical and non-clinical needs by facilitating connections to other providers that are best suited to meet those needs. In addition, these centers coordinate care for people with Medicaid coverage, and treatment is team-based and whole-person focused, integrating behavioral health and primary care. They are not limited to providing services within the walls of their physical locations. The COEs were designed to help clients with OUD achieve optimal health, well-being, recovery, and choice by minimizing treatment gaps, providing intensive physical and behavioral health care coordination, expanding access to MOUD, helping engage and retain clients at high risk for overdose in the community, and ensuring access to high-quality, evidence-based OUD treatment. The Fidelity guidelines provide suggestions for care management activities within each phase outlined previously. First, engagement and stabilization. In the first month, the primary focus is retaining the clients in COE services and connecting to services and providers to assist in HRSN or SDOH barriers. Encourage clients to integrate family members in the program during the engagement phase and provide family members with education on the client's service options and needs. For example, the benefits of MOUD, need for long-term care, etc. The COE can obtain ROIs for family members and/or natural supports at the time the client is agreeable to involving these individuals in their care. Any emergent medical or mental health needs can also be addressed in this phase through coordination of care, such as referral for pre- and postnatal care or psychiatric consultations, for example, hospitalization for suicidal behaviors. Depending on the makeup of the care management team and provider type, some physical or mental health needs can be addressed on-site without referral. Focusing on active substance use and harm reduction behaviors during the first 30 days is critical, as COEs are intended to enroll the clients who are at most risk of disengagement. All clients should receive the brief assessment of recovery capital, BARC 10, in the first 30 days. BARC 10 scores must be utilized by COE staff to assist clients in building recovery capital. The BARC 10 should be repeated every 6 months. One of the guiding principles of the COE is that the COE will assertively engage individuals with a history of emergency department treatment episodes for opioid use, individuals with a history of inpatient or residential substance use treatment, individuals with a high risk for overdose, individuals with opioid use in addition to polysubstance use, and individuals with current intravenous drug use. The assertive engagement mentioned in this principle is important to COE services in general, but could be especially important to consider in this first phase of care management, where the focus is on harm reduction and reducing substance use. There has been previous training for COEs related to proactive outreach, which is similar to assertive engagement. Proactive outreach is a broad concept that involves reaching out to individuals or communities before a problem arises or escalates. It encompasses a proactive and preventive approach to addressing issues rather than waiting for individuals to seek help or waiting until a situation becomes critical. While there is no single definition of proactive outreach, it generally involves actively engaging with individuals or groups to provide support, resources, and assistance, often in a personalized and timely manner. Proactive outreach contrasts with reactive approaches that have been used traditionally. Reactive treatment is designed to address problems after they have already occurred or when individuals actively seek help. In a reactive model, individuals often need to recognize and acknowledge their issues and take the initiative to seek assistance. There are many benefits of proactive outreach documented in the literature. Proactive outreach efforts have been associated with a decrease in hospitalization rates. By reaching out to individuals before their conditions worsen, proactive interventions can help identify and address issues at an early stage. By intervening proactively, hospital admissions due to crises can be reduced. Proactive outreach can significantly improve medication adherence among individuals who require ongoing treatment. By establishing regular communication, monitoring medication usage, and addressing barriers to adherence, proactive outreach can help individuals stay on track with their prescribed medications. Proactive outreach initiatives have shown success in reducing rates of homelessness. Proactive outreach efforts may involve identifying individuals who are insecurely housed, providing access to temporary or permanent housing options, connecting them with social services, and assisting with employment or income support. Proactive outreach can have a significant positive impact on individuals' quality of life and overall functioning. By providing early intervention and ongoing support, proactive outreach can help individuals manage their conditions, access necessary treatments, and develop coping strategies. This can lead to improved physical and mental well-being, increased social integration, and enhanced self-efficacy, as well as higher overall quality of life. Proactive outreach efforts have been linked to decreased rates of criminal justice involvement. This can involve connecting individuals with appropriate mental health or substance use treatment services, addressing social determinants of crime, and offering alternative pathways to rehabilitation. Proactive outreach initiatives have the potential to reduce costs within the healthcare and social service systems. By preventing crises, reducing hospitalizations, and promoting early intervention, proactive outreach can mitigate the need for expensive emergency interventions and acute care services. Additionally, by addressing social determinants of health and providing support in the community, proactive outreach can help individuals maintain stability. Both the hub and spoke model and proactive outreach have been expanded upon in previous trainings, and the recordings of these trainings could be valuable for COEs as they implement the stepped approach to care management suggested in the Fidelity guidelines to best serve the high-need individuals who are most in need of the enhanced care management that is offered by the COE program. Harm reduction was also referenced in the first phase of the stepped approach to care management. Harm reduction, defined by the Substance Abuse and Mental Health Services Administration as an evidence-based approach that is critical to engaging with people who use drugs and equipping them with life-saving tools and information to create positive change in their lives and potentially save their lives. This is becoming more widely accepted and used. In 2022, SAMHSA embraced a harm reduction framework, marking a shift in addressing drug-related public health issues. Through the American Rescue Plan, SAMHSA introduced its first ever harm reduction grant program, aimed at enhancing community-based harm reduction services and supporting efforts to prevent overdose deaths and mitigate health risks linked to drug use. In March 2024, the UN's Commission on Narcotic Drugs took a historic step by voting on a resolution for the first time in over half a century, notably adopting language on harm reduction during its 67th session in Vienna. This marked a significant shift in international drug policy, highlighting a growing consensus on the importance of harm reduction strategies in addressing substance-related health issues. COEs play a vital role in harm reduction efforts, actively incorporating harm reduction strategies such as naloxone distribution and helping with other safe use strategies based on client need. During the first phase of care management, harm reduction is important to ensure that clients are safe and feel they have a supportive environment to return to for continued support with their recovery. Peru has previously hosted COE-facing trainings on harm reduction, and these recordings are available to review for additional information on this important topic. In Phase 1 of the Care Management section of the Fidelity Guidelines, it is stated that the BARC 10 scores are to be utilized by COE staff to assist clients in building recovery capital. There are many benefits to addressing recovery capital as part of the COE's enhanced care management offerings. These include improved long-term recovery rates. Utilizing strategies that target family and community recovery capital can significantly improve long-term recovery outcomes, leading to sustained recovery and higher quality of life. Tailored treatment plans. Recovery capital assessment allows for more personalized care. Those with higher recovery capital may require less intensive forms of treatment, optimizing resource allocation and individual care. Environmental impact. Addressing recovery capital considers the environmental factors that can either enhance or negate the effects of short-term clinical interventions. This provides a more holistic approach to treatment. Coping and resilience. Increases in recovery capital can boost coping mechanisms and enhance resilience, critical factors in both initiating and maintaining long-term recovery. This mitigates the biological and psychological stress often associated with recovery. Trigger for positive life changes. Any increase in recovery capital can act as a catalyst for further positive changes in an individual's life, such as gaining employment, rekindling family relationships, pursuing education, or securing stable housing. Enhanced quality of life. Beyond merely treating substance use disorder, focusing on recovery capital contributes to an overall better quality of life, which includes the strengthening of social ties and improving life circumstances. To support COEs in using the BARC-10, Peru offered a COE Learning Network session titled Using the BARC-10 as a Tool to Support Recovery. You're welcome to review this training recording in tomorrow's healthcare. Moving on to the integration of global health and skills training section. In the second phase, assuming clients can be engaged or re-engaged in COE services, for example, when the client does not need to be transferred to another COE or an inpatient or residential program, begin to focus on screening, assessments, and care management activities on more global healthcare and co-occurring needs, as well as social support systems that can help clients stay actively involved in any behavioral health treatment. Care managers can focus on gaps in HRSN, SDOH during this phase, as well as mental health and primary care needs and services, which can include dental, pre- and postnatal care, HCV and HIV screening and treatment, and others. During the second phase, focus consistently on clients' substance use patterns, as most disengage because of ongoing substance use, even if they want COE services. Substance use patterns should be monitored weekly, if not more frequently, for those who are known to disengage and re-engage. Substance use can be assessed through biometrics, weekly check-in for risk of substance using patterns, and monitoring of emotional states known to trigger substance use. For example, weekly screening or check-ins using the PHQ-9, GAD-7, or other validated psychiatric scales with psychometric properties are encouraged but not required due to differences in COE provider types. If the client is receiving behavioral health or substance use treatment within your facility, it is recommended that care team meetings be conducted to ensure that all members of the client's community-based care management team stay informed. Integrate family members in the client's care management plans, as family members can help re-engage clients during this phase. Help family members see the value of MOUD, as well as how to provide support. The integration of family into clients' care management plans is the client's choice. However, COE staff should encourage involvement. The second phase of care management mentions the importance of team meetings to ensure all members of the community-based care management team are well informed about each client. To understand the ideal community-based care management team components, refer to Appendix 18. In addition, Peru hosted a learning network session about team-based decision-making, where COEs shared their processes for making decisions as a multidisciplinary team. This would be a good tutorial to consider how each member of the community-based care management team can support a client in a collaborative fashion. The third phase of care management outlined in the Fidelity guidelines is expansion of recovery capital, skills training, and transition to self-management. During the third phase, focus on expanding social supports for clients through educating family members on helping clients manage urges, family therapy to reduce stigma, and/or coaching on how to support recovery. For example, community reinforcement approach. Focus also on addressing critical healthcare needs, such as screening and treatment for HCV and HIV, if not already done in phase 2. sexually transmitted diseases, smoking cessation, and medications for those who smoke cigarettes are also items to be addressed, along with any unmet health-related social needs, SDOH, or recovery capital needs, such as education, employment, or expanding social networks. The third phase is also used to identify a PCP or FQHC or OTP where clients can receive MOUD and healthcare services beyond the COE. The BARC 10 should be assessed at 6-month intervals to demonstrate recovery capital. Successful discharge includes enrolling clients in a PCP, FQHC, or OTP where they can receive ongoing MOUD and healthcare services. You will notice that the third care management phase outlined in the COE Fidelity guidelines emphasizes connecting clients to social supports as they move further in their recovery journey. These natural supports are important for COEs to consider in phase 3 with the emphasis on social support. Community supports, including natural supports, refer to the resources inherent in community environments. They typically involve personal relationships and community associations that enhance life quality and security. These supports are often reciprocal and often informal, contrasting with formal paid support services. Here are some of the benefits of natural supports. Engaging in a diverse array of relationships encompassing family, friends, colleagues, and community connections has been shown to significantly contribute to overall health and increase lifespan. This variety in social interactions enriches our experiences and provides comprehensive support networks that enhance both mental and physical well-being. Research has consistently demonstrated that individuals with robust social relationships have a markedly higher chance of survival. This is attributed to the psychological and physiological benefits gained from social interactions, which can reduce stress, improve mental health, and encourage healthier lifestyle choices. Natural supports provide crucial emotional and social benefits. They cultivate a sense of belonging and dignity, boost self-esteem, and empower individuals towards greater independence. These relationships are important in shaping our identity and providing a secure base from which we can confidently navigate life's challenges. By leveraging natural supports, there's a significant reduction in the dependency on formal service systems. These organic forms of support, emerging naturally within one's social and community network, are more accessible, culturally relevant, and often more effective in providing real-time personalized assistance and emotional backing. Within the care management approach laid out in the Fidelity guidelines, there is discussion of referral partners. COEs can refer to Appendix 20 within the Fidelity guidelines for information about developing clinical collaborations with COE partners. MCOs can use claims, REDCap, and pharmacy data to identify when clients are disengaging from the COE and what types and frequency of care management services are being offered. MCOs may look for discrepancies in intensity of care management services. For example, if everyone receives one contact per month. They can also look for disengagement rates. REDCap quarterly summary reports will provide comparison aggregate interaction data, which can help to identify patterns of disengagement. MCOs can also provide resources and support on using a combination of stepped care for counseling and care coordination, family training, harm reduction for those who are using other substances without a decrease in use over time, and dosing patterns to address relapse risks. For example, increasing dosing when still using opioids or other substances. MCOs are also encouraged to develop a file sharing protocol with COEs related to the enrollment and recertification of Medicaid. This will help to ensure that clients remain covered for COE and other Medicaid services. MCOs should consider VBP models that encourage rapid access to MOUD and intensive services within the first and second phases of the COE program. Additional MCO guidelines related to the care management section include offering resources and support on how to use simple monitoring tools to assess risk of substance use, suicide, and symptoms of behavioral health disorders, for example, anxiety, depression, or PTSD. MCOs should help COEs to lower burden of paperwork to complete screens or delay some assessments if clients remain difficult to engage, and help COEs to develop low barrier protocols to provide buprenorphine or methadone, even if clients struggle to engage in other SUD services or continue to use illicit substances. This may mean looking for policies that remove clients from treatment for ongoing substance use. Behavioral health MCOs should help COEs coordinate services with SUD inpatient and residential programs and monitor the risk of disengagement due to disruptions in coordination of care between the COE and inpatient residential providers, such as elimination of MOUD during the inpatient and residential stay or transfer to a non-COE program upon completion of the inpatient residential stay without coordination with the COE. MCOs can confirm through chart review that the COE is using a care plan that includes the client's treatment and non-treatment needs as identified on the full health-related social need, social determinants of health screening, and goals, objectives, and/or action items to address those needs, and that the care plans contain documentation such as a signature that the client agrees with the goals and participated in the development of the plan. The MCO may confirm that the care plan was signed by the client and the COE team member who developed it, and that the care plan is updated as indicated. Through chart review and/or review of COE's policies and procedures, MCOs can confirm the documentation of items related to care management outlined in the Fidelity Guidelines documentation guidance. In the previous sections, we discussed the documentation requirements for COE enrollment and initial assessment. Following enrollment and initial assessment, subsequent care management visit notes should include documentation of the development of an expanded care management plan completed by the end of first 2 months, documentation within the expanded care management plan, such as a signature that the client agrees with the goals and participated in the development of the plan. The client, the care manager, and other individuals on the community-based care management team, or as specified by the COE organization, should sign the initial and all subsequent care plans. Documentation of client's phase of recovery, with care plan goals aligned to the appropriate phase. Documentation of continuous assessment based on the client's stage of readiness and timeframe in the COE, including BARC 10 assessment every 6 months. All care management notes should include documentation of the activity that was conducted to bill the G9012 code, length of time of visit, how the visit was completed, virtual or in person, where it was completed, in the office and which satellite office or in the community, who completed the care management visit, needs that were addressed or referrals placed, the care management plan goal addressed during the visit, and the referrals the client received. If the client received referrals at the previous visit, best practice is to document follow-up to ensure services were received. When services are confirmed as received, they should be documented in REDCap as service performed. And finally, the next planned activities for the community-based care management team and the client. There are 2 care management documentation guidelines that should go in the COE's policies and procedures. These are the COE's mobile engagement policy and the applicable telehealth policy. If you remember the earlier mentioned guidelines, mobile engagement is encouraged and telehealth should be allowable for care management if it complies with OMSAS and OMAP policies. These are the references used for this tutorial. Thank you for joining me for this tutorial about the care management section of the COE Fidelity Guidelines. Please contact your Peru TA provider with additional questions or requests for support.